Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Examining the Drivers and Outcomes of the U.S. Dental Therapy Movement Through a Health Equity Lens. And it was presented on April 8th by Beth Mertz, and she was joined by our guest moderator, Patricia Pittman. First of all, welcome to our webinar. My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. Today's event is the first in a series focused on health equity, and it is entitled Examining the Drivers and Outcomes of the U.S. Dental Therapy Movement Through a Health Equity Lens. And with that said, I'm going to go ahead and turn our event over to our moderator, Polly, otherwise known as Patricia Pittman. Polly is the director of the Fitzhugh Mullan Institute for Health Workforce Equity, located at the George Washington University. Polly, would you like to introduce our speaker?
Sure, thanks, Dave, and thanks for organizing this important panel. It is my pleasure to introduce Dr. Beth Mertz. Beth will be speaking to us about the drivers and outcomes of U.S. dental therapy movement and its relationship with health equity. I think the topic is particularly timely. We all have health equity on our mind these days as a result of COVID. I think there's perhaps no other area of healthcare that is as adversely impacted by inequities as oral health. We know that these are problems that are absolutely preventable and have dire consequences. And as a result of sort of a complicated quilt of policies and programs, we have a workforce that is not attending to the population need. And so this topic is particularly important because it is one of the ways that researchers have identified sort of options for expanding the workforce and improving access to care and thereby reducing problems of inequities. Beth is a professor at the University of California, San Francisco School of Dentistry. She's affiliated with UCSF's Center to Address Disparities in Children's Oral Health, better known as CANDO, as well as the Philip R. Lee Institute for Health Policy, as well as Healthforce Center, which is the Health Workforce Research Center at UCSF. While her research encompasses a broad range of health services research topics, she's obviously best known for her work on the oral health workforce and precisely this question of access and scope of practice barriers. She received her undergraduate degree from the University of Southern California, a master's in public affairs at the University of Minnesota, and her PhD in medical sociology from the University of California in San Francisco. So Beth, welcome and thank you for your presentation. We're excited to hear from you.
Okay. Well, this is a short presentation on a very large topic, so I will try to be very concise, but there's probably 100 more things I could add than what I'm able to put in the next 10 minutes. But thank you for having me here today, and I'm happy to participate and share some of the work that we've been doing for the last 4 years. So what I'm going to try to cover today is three things. First, really to define dental therapy and explain the current status of this occupational spread in the United States. Second, to describe the drivers of the dental therapy movement. And then finally, to really examine evidence of upstream, structural, and downstream health access and status outcomes of dental therapy using a health equity lens. The data that I pull from is extensive. It comes from a 4-year evaluation of the dental therapy movement conducted at UCSF and funded by the W.K. Kellogg Foundation. And there's also data in here from an evaluation of the use of dental therapists in Minnesota, particularly at Appletree, that has been conducted by my colleagues at SUNY Albany through our Oral Health Workforce Research Center. So I'm pulling from several different sources. So what is a dental therapist? Dental therapists are primary dental care providers. They're used globally in over 50 countries and introduced to the United States in 2005. They work as part of the dental care team to serve children and adults, and they provide clinical and therapeutic care, including prevention and routine restorative care. The global use of dental therapists and their safety and effectiveness have been demonstrated in various health systems. So although this is a new provider in the United States, this is a very well-established occupation globally. So how did we get to where we are here? I've put this timeline together to kind of walk us through. Students initially trained in New Zealand's long-standing dental therapy program and became the first practicing dental therapist in the United States in 2005 in Alaska. And this was made possible under the Community Health Aid Program, which is a federally recognized program authorized and part of the work of the Alaska Native Tribal Health Consortium. So in 2005 is when we saw the first practicing dental therapists in Alaska. In 2009, Minnesota was the first state to pass legislation creating both dental therapists and advanced dental therapists. So we have these two initial but very distinct efforts that led to interest in expanding the model nationally with heavy investment from philanthropy, and culminating in what we have now, which is called the National Partnership for Dental Therapy, a coordinated effort between tribal governments and advocacy organizations to advance equitable oral health policy for all. Quickly following, a few years later, Maine and Vermont were passed bills to authorize dental therapists, and dental health aid therapists trained in the program that had been set up in Alaska began to practice in tribal settings and pilot projects in Washington and Oregon. The movement really gained speed in 2018 with 2 additional states passing, Arizona and Michigan, and then in 2019 with 5 additional states passing or authorizing dental therapy in some way. Finally, and importantly separate from the authorization piece, is in 2015, the Commission on Dental Accreditation approved guidelines for dental therapy education programs. And in 2020, the Ilisavik College, Alaska's only tribal college, was the first to gain CODA accreditation for their dental therapy program. Currently, in 2021, we have 5 states, with 13 states that have authorized and 5 states that have dental therapists actually in practice. So what are some of the drivers for change? Really, there's a very strong community engagement factor that underpins this dental therapy movement. The genesis of dental therapy in Alaska was rooted in tribal self-determination through community-driven initiative to remediate historical oral health inequities and trauma. For tribal nations, the strong focus on developing their own local workforce of dental therapists, culturally and linguistically tied to the communities they serve, shifted oral health care from something only accessible from a small pool of existing providers to something attainable and built for themselves. The local economic benefit of a dental therapy within these sovereign nations was also stressed by communities as a critical driver. In state-based efforts, dental therapy garners wide bipartisan support from groups as varied as grassroots social justice and community advocates to healthcare organizations to libertarian free market groups. Advocates' unifying message of health equity has been instrumental to the movement's success over time in the face of sustained resistance from organized dentistry. So this really is a community-led, community-built response to a longstanding issues of lack of access and need for better economic opportunities. This chart is large, I know. It shows the variability in the implementation of dental therapists across the states. It's sort of ordered by the year of authorization. A couple of critical differences include the degree requirements in Minnesota and Maine, as well as dental hygiene prerequisites in a number of the states. So dental therapy, based on the CODA standards, and based on the initial implementation, really is a standalone and separate occupation from dental hygiene. They need to be licensed as dental therapists, but they do share some competencies, and so some states have chosen to link them. While implementation is far from achieved in many states, the legal, organizational, and educational frameworks for this occupation are now firmly established. Dental therapy was designed and implemented worldwide to increase access to oral health services through public health practice based on equitable principles and objectives. Common education standards we have now through accreditation. We have model legislative language that provide a clear and evidence-based roadmap for other states or tribal nations seeking to authorize dental therapists in a flexible enough system to allow local adaptations while maintaining universal standards. So now I'll talk a little bit about the impact on health equity. The evidence based on safety, acceptability, and outcomes that have been developed is at this point irrefutable. Where dental therapists are fully deployed, quality of care is high, and improvements in access and patient outcomes is well established. As well, health equity in workforce opportunity comes particularly from programs at the community college level, where education is most accessible and affordable within the broad set of higher education. So I just want to share a quote from an Alaskan tribal member. Hope is in a place where it didn't exist before. I've seen the devastation in those villages, and now we have people who have a good job, have a positive force in their communities, in tribal councils, on school boards. They're role models, helping out kids that need a safe place to live. This is huge for the communities that we're targeting, providing so many more benefits that I could ever imagine. Alaska is the most studied program over time, from initial training and deployment into the health system and impact on communities. The positive outcomes are most notable from an equity perspective because the Alaskan Native population has been among the most disadvantaged with extremely high oral health disease burden. I also want to note that the fact that Ilisavik College is perhaps one of the only examples of a truly decolonized educational pathway in dentistry, focused entirely around training local people for local needs. This approach is being used as a model for the Skagit Valley College at Swinomish Dental Clinic partnership that's under development in the state of Washington. The impacts on access to care have also been shown under this model. And I'm just showing a little bit of data from Minnesota. Dental safety net facilities have been great supporters and early employers of dental therapists. A survey of 32 safety net providers reported that clinical directors overwhelmingly support the dental therapy provider model. Minnesota also allows dental therapists to be employed in private practices that serve Medicaid, and dental therapists are serving populations traditionally classified as underserved. The Oregon pilot projects are under evaluation, and preliminary results in both Oregon and Washington, as reported by the stakeholders we interviewed, have also been very positive. Finally, this is an infographic that's available at our Workforce Center website that shows a number of things about the spread of dental therapists around the United States. For underserved communities, achieving long-term structural changes that drive equity through workforce strategies such as dental therapy requires gaining occupational legitimation through institutional change, while also challenging those institutions' often racist, paternalistic, and colonialist structures and processes. The dental therapy movement seeks to both integrate into this ecosystem as well as challenge the traditional silos, which have exclusionary impacts both for providers and for those that they serve. When I look at this infographic, I see the progress that's being made in the West, Northeast, and Midwest, and I also see the opportunities in the South, particularly to address racial disparities in the African American population. It might look different in the South than it does in tribal communities or other areas. But that's what's so amazing about dental therapists is that by engaging the communities and really developing community processes, community education, and ways to integrate into local communities, as well as employment opportunities, I really see a huge opportunity in the South specifically. Unfortunately, it has been the area that's been most resistant to scope of practice change in dentistry, which is why we see no progress in there. But I think when we're thinking more broadly about not just oral health equity, but the critical issues of racial justice in our society in the United States right now, that this is something we should be looking at. So finally, I just have a few, these are my ideas, I own them. In terms of ways that the federal government, state governments can help advance health equity through support of dental therapy as an occupation. I think unsurprisingly, most workforce intervention strategies focus on downstream sort of health access factors where health professionals, the traditional health professionals, have control over practice without actually challenging the structures that precipitate oral health problems. Conversely, an upstream approach to workforce changes the power balance by bringing the communities into the production of health and centering the knowledge and factors important to that community. Dental therapy is unique in illuminating a pathway towards health equity by modeling how to deconstruct traditional hierarchies and address the oral health of communities through truly community engaged and community responsive oral health care. So there are a number of things that could be done, investing in the development of education programs, which are still needed in many of the states, including dental therapists in the list of clinicians under federal training programs, partnering with federally qualified health centers to expand training and employment in these sites, adding them as eligible clinicians under federal and state loan repayment programs, certainly partnering with CMS and state programs to ensure payment parity for their services, and then Indian Health Service can incentivize expansion in the states where authorized. And I just want to note that there is a federal job description under the Community Health Aid Program for dental therapists, so that infrastructure is in place. Finally, just a few acknowledgements. I couldn't do any of this work without the amazing research participants. Almost 100 people across the country gave generously of their time and expertise to help us complete this evaluation. We have a fabulous team at UCSF, a number of consultants, the SUNY team, and of course, the funding without which we would not be able to do this work. Thank you. That's the end of my presentation. I'm happy to take questions.
Thank you, Beth. So I wanted to kick off our Q&A session here with a couple of questions of my own, and I see that we have questions coming in, so that's great. Keep them coming. So the first question is just a detail that I didn't hear and just would be helpful in terms of understanding the picture. what do the wages look like across the country for dental therapists, and how does that compare to dentists and other personnel within the oral health workforce? And who is employing these people? Are they employed by dentists' offices? Are they employed by agencies or public sector?
Yeah, it varies. So I'm going to just go back to the slide that has this one here that has the wheel. So the supervision level, you could see dental therapists have to be supervised by a dentist. So they can be employed in a variety of settings, and that doesn't mean direct supervision. So for example, in Minnesota, Children's Dental Services, they have dentists, but also many dental therapists, and the dental therapists go out into the communities using mobile services or remote clinics to provide services, so forth. As well, in Alaska, they work in the Alaska Native Tribal Health Consortium, where they have a hub and spoke sort of a system, where they might have a clinic in a place like Bethel with the dentist, but then the dental therapists are actually out in the small remote communities, and then just coming back to the, referring people if they need additional care, but doing as much as they can in those communities. There are population and setting restrictions. So in Minnesota, for example, dentists can work, or dental therapists can work in a dentist's office, but that office has to serve Medicaid populations. So it's really sort of a broad swath of things. In Washington State, the Swinomish tribe actually built their own dental clinic, and they have dentists, but then also employ dental therapists and are serving as a clinical training site for dental therapists there as well. So it's really in development. As far as the wages, they are lower. I don't have off the top of my head what like an actual wage is that is being paid, and it probably varies. But the economic data that I've seen has shown that when you bring a dental therapist into the team, it benefits the whole practice. They are able to be more efficient. They're able to see more patients and do more with less.
Presumably the wages are sort of in the 60s, 70s, 80s, kind of like a nurse. I mean, these are good wages. They're
yes.
Not, yeah.
No, that would be my assumption. And again, I'm sorry, I don't have that right off the top of my head, so I can't give you a confirmation on that. But it is for the individuals that are working in these fields. It is a very good opportunity and a good healthcare job. Yeah.
So I wanted to sort of zoom out a little bit and think about this phenomenon of an emerging occupation. I think in some ways, my understanding of this has changed as a result of your presentation, Beth, and I appreciate that this is, not just an issue of scope of practice. This is actually sort of a cultural shift and a different model of what a health occupation could be. That is super interesting and in some way reminiscent of what the nurse practitioner movement intended for NPs when they began as an alternative model, not just as cheaper labor, if you will, to improve access or distribution of the physician workforce. So not just as extenders, but as actually a different kind of animal. Recognizing that and recognizing that how important and interesting that is for other occupations too. I'm thinking about community health workers in particular, about affirming their alternative models and being able to protect those as they evolve as a profession going forward, being both an objective and a challenge to achieve. But the scope of practice battles, as we call them, obviously are not unique to dental therapists, and they are particularly ferocious for this sort of swath of the health workforce that we call advanced practice clinicians. And yet, because the research on cost and quality and safety is so overwhelming, and because the needs for additional providers is so evident in certain areas of the country, there seems to be, historically, we are inevitably moving towards greater scope of practice for this swath of the workforce, right? I mean, it's, a limited number of states now, but it's growing. And the same has been happening with other health professions that occupy the same sort of strata within the hierarchy. And so I I guess I would ask you just in a sort of futuristic question about, 10, 15 years from now, what role you think dental therapists will be playing in the oral health system, and whether you think there are major payment or sort of political impediments that will prevent the advancement of this model, or do you think that the march of history is positive and we're going in the right direction?
Yeah, I mean, I don't have a crystal ball on this. I think, the National Partnership for Dental Therapy is well established in terms of continuing their advocacy and continuing to work with state partners to bring this model forward. To me, it really seems that, in the more traditional professional hierarchy, there's been a perspective of, we must do things for underserved communities. We come and we save them, we come and we help them. Where I think what dental therapy and what the movement that is trying to bring dental therapy is really doing is saying, no, we know what we need. We understand what our issues are, and we want to be leaders. We want to partner and be leaders in the development of systems that are for us, by us, as opposed to being sort of at the mercy of someone having goodwill to come in and then deciding they want to leave and going back and forth, and really building that community capacity from the ground up. And, I do think that we see this in other occupations. The community health workers, I think, is a great one. But the dental hierarchy has been pretty established for over 100 years. And so this is change. Change is hard. The only opposition to dental therapy is organized dentistry. And I don't understand why they continue to be opposed to it, given how fast it's spreading and given the outcomes, and that they don't replace the dentist, they work for dentists, and they also expand access. And so I think that's, I don't see that opposition going away anytime soon. I wish that it would, but that is really, I think, the thing that the influence of that is really the thing that's kind of keeping the movement from going at, I think, a much faster pace. I think now that we have, 13 states, and the more that we see these individuals being trained and going out to practice, I think the more states we're going to see work to adopt it, because it's always hard to be the first one and kind of innovate, but then once it's pretty established, as I said, the legal organizational practice framework is established. There's nothing, it just needs to be adapted and adopted.
Okay, so let me turn now to the questions that are coming in from our audience. I'm going to start with two that seem related. I know you mentioned that there was model legislative language, which is a terrific resource. Jessica's asking whether you know of any other resources that would be available to assist in getting legislative language implemented. So it sounds to me that she's interested in sort of strategies and resources around strategies. And Alex is also asking what you would recommend to community leaders on how to engage their state ADA in a dialogue. So the dialogue with legislators, the dialogue with the Association of Dentists, and whether you have sort of strategies that are tried and true and resources that people can use as they begin this work.
Yeah, so there's a Dental Therapy Resource Center that is a website that has a very large set of resources around dental therapy. So I would start there. And also with the National Partnership for Dental Therapy. So those groups have been working on these issues on the ground, from everything from developing the community groups to getting the legislation to getting through the that regulatory process after legislation is done. And those would be your best resources. I'm a researcher at UCSF. I'm not on the ground doing this work. I'm just reporting back on the amazing things that they're doing. So I think that those are the places I would recommend for more resources. In terms of engaging the ADA in a dialogue, I haven't seen a good example of where that's gone well. So I wish I could say I
For examples of where it's gone poorly could also be very
well,
illustrative.
those abound. I believe in Connecticut, actually, that the Dental Association was supportive of the bill that they just passed. And maybe that would be a place to talk to some folks about, how that positive relationship was developed and moved forward. I do think that what we have seen in all of these other states is the groups just doing the work and not partnering with the Dental Association because they were not willing to partner. They were not willing to have a dialogue about it. They're staunch opposition. And so unfortunately, that's the way that this has been gone. And that's why it's taken so long for some of these steps to happen. In the regulatory space is also where we see continued resistance. So even if a law is passed, you see sort of attempts to then use that regulatory process to severely limit what people can do, where they can practice, how the other various things. So it is an actually really critical step to get through that, that regulatory process with the dental boards and the Medicaid agencies and so forth, and to not think that, well, you got the piece of legislation passed and now it's a done deal. Even more, pardon me, even more after that is getting the educational program set up, getting the clinical infrastructure and so forth. And that's why we see only 5 states that have education and practicing dental therapists compared to the number that have the authorization, because that infrastructure takes quite a while to happen. Although we are seeing some interstate movement. So folks trained in the Alaska program have been working in Oregon, Washington, and soon in Idaho and Montana, where a graduate from Minnesota is now the first dental therapist working in Maine. So but those regulations, the difference in the regulations and the requirements is a problem for interstate, is going to create a problem for interstate movement. And there will at some point need to be some reconciliation about what that looks like.
Okay, well, that's a good segue to a number of these questions relating to training.
Real quickly, Polly, just to interject, we are at the half-hour mark, which is the time we allotted for this event. With that said, as you point out, there's several great questions in there still. Can y'all stick around for about 5 to 10 more minutes, or?
Sure.
Great.
I can, sure.
Great. And for those of you in the audience who have another event to attend, we are recording this, so the full video, including all the Q&As, will be available on our website in the near future. With that said, by all means, get to these more outstanding questions. Thank you.
Okay, well, we can try to combine some of these questions. So general information on the educational training for the DHAT. There's an interesting comment from Alan about this requirement that folks get a dental hygiene degree first, because it's supposedly safer. If you could address that.
Yeah, I'll address that. The CODA accreditation and the model that has been adapted globally does not require those things. So a baccalaureate degree or a master's degree.
Accreditation for programs.
Yeah, the CODA accredits a program. So there's no degree requirement to get accredited. And really this has been historically a 2-year post high school entry level, not entry level, but like, really like first degree kind of program at a community college or so forth. So we have seen the add-on of dental hygiene in a number of places. So dental hygienists have long wanted to have an advanced dental hygiene practice. So when you pair dental therapy with dental hygiene, you essentially get an advanced dental hygiene practitioner. And so the political process of that has merging those in a number of places. Again, you can be a dental therapist in the DHAT model, the Alaska model, without any of those requirements. And that's actually the program that first got CODA accreditation. So there are a number of complications. And again, it gets back to this kind of a lot of the politics and the history and this idea that, more is better, where from an equity perspective, the more barriers, the more years of training that are unnecessary that you add on top, that really actually reduces the equity from a workforce perspective, in terms of making it an opportunity for students that otherwise wouldn't be able to go on to these types of training.
following up on Joseph's question about sort of competency as a cultural issue versus a training issue, does CODA address that issue of cultural competencies, or how is that in the selection of the students, or how are they thinking about that?
Yeah, again, it varies. I think in the Alaska model in Ilisavik College, it's a tribal college, and it's primarily individuals who are selected by their tribes to go get this training and then come back and work. So they have cultural competency. They don't need to learn that. In Minnesota, where the programs are based both at the University of Minnesota, and they're right alongside training alongside the dental students, as well as there's a community college and a state college partnership now, and I'm forgetting the name, I apologize. But those require 3 years. You get a master's degree, and then maybe they have a cultural competent component. I don't know the answer to that, but I do know that those individuals are often working in communities in Minnesota that have traditionally been underserved. So it's a great question. I don't know the CODA requirements, but I do think that particularly when you're recruiting from the community, partnering with the community, recruiting members from that community so that they can go back and work in their own communities, that idea of having that community connection and cultural competency is implied.
So I want to end on the HRSA question and what HRSA can do, but there's a question from Kathleen that is sort of a technical issue. If it would be okay for dental therapists to work at a supervising dental private practice, seeing quote unquote regular patients, and then go to a different community to see all underserved patients to fulfill the 50% underserved requirement. Would that be acceptable?
It really depends on the state, again, on like where they are. So if you are a member of a tribe and you're working in a tribal health center, or in your tribal community, I don't think that would really apply, I guess. In some of the state models, you would have to work with the regulatory board of what that actually looks like. So I believe in Minnesota, the requirement is that the private practice that employs the dental therapist has to serve a certain amount of Medicaid patients. There are other states, I think Arizona, their requirement is that they can only work in a federally qualified health center. So private practice isn't an option. So we also have, again, as we always do in these scope of practice issues, this natural experiment where every state's going to do something a little bit different, and everyone's going to try to figure it out. And then, 10 years from now, we'll have evidence that some of these restrictions are pretty silly, and we need to, let them go or move along. And some of the barriers maybe will be lowered so that we can continue to work towards what the goal is, which is really equity and oral health, and bringing services and opportunities to communities that have been historically marginalized.
So you talked about the importance of getting up the educational infrastructure. Setting that up is no small matter, and I know HRSA has supported the program in Vermont, right? Can you talk about sort of what your number one recommendation for HRSA would be in terms of refocusing their investment in this workforce with a particular eye on impacting health equity?
Yeah, it's a good, I think when you look down this list, a number of the training programs, having them be eligible clinicians, so forth. I think there are some changes where it's just a matter of saying dentists, dental hygienists, and now dental therapists can apply for a loan repayment program. So there's some sort of small changes that are, and I say small, and I know in the bureaucracy, it's never as small as anything seems. But there's some changes that are just adding them into the existing programs. The
National Health Service Corps.
Exactly. That might make a difference and just open up those opportunities. I do think, and you could certainly talk to the director of the Vermont program about her experience, but I know the HRSA investment has been really helpful in them trying to get their program up. The development of mapping these programs onto existing programs, whether it's at community baccalaureate level or master's level, it's not a small undertaking for the people that have to do it. So having that investment in the resources to really focus and do that work and learn from the others who've done it before and apply best practices, I think would be one of the places that I would see having the biggest immediate impact, because so many states who've authorized don't yet have education programs. And so really being able to, take that next step in the development of the pipeline.
So we have a number of comments in the chat box, and I'll just read through them for the benefit of the recording, so that these thoughts are shared with the future audience. Betty points out that dental therapists will play a huge positive role in providing access to care to the underserved. You said it, the only opposition to dental therapists is organized dentistry. This is a disservice to those that need care. And Colleen actually has a question: can dental therapists be sustained without organized dentistry support? And if yes, how? I'll let you answer that after we read through all of these, because I know we have a time limit here. Betty comments that MNDA was supportive once they recognized that the profit financially and professionally, that they could focus on procedures they preferred to do, and the dental therapists could do the fill and drill. Betty also comments that dental therapists that work in private practices with requirements to see Medicaid patients aren't only seeing Medicaid patients. They're licensed to provide their services to all patients without scope. So mostly comments here, and I don't know if you wanted to mention, can you proceed without organized dentistry support? It sounds like if they're going to supervise, it's pretty important to have some dialogue with them, huh?
Well, the movement hasn't had organized dentistry support yet, but you can see looking at the scope of practice wheel that they've made a ton of progress. And if you look at this outer bar, the purple, these are the number of states where there's either a prior or active campaign for dental therapy. So community advocates, this is something that people have put years of work into. And it's unfortunate that they've had to have the resistance that they have, but it doesn't, it seems that they're making progress in spite of it. And my guess is that now that this work has really been formalized and the infrastructure is there, that it will continue to progress.
So even if the organizations are not supporting the legislative change at the level of individual dentists, they actually do get with the program once the programs are up and running, and do provide the supervision and do hire them.
We have not heard it. Generally, what I have heard from the stakeholders we've interviewed is that once folks really understand the model and work with these providers, they convert to being supporters. And we see Dentists for Health Equity, the new organization Dentists for Health Equity being formed specifically around those groups of people who want to, that'd be, I'd say, the one place where there's quote organized dentists, I guess, that are, advocating for this and in support of this towards the broader mission. So, yeah.
Well, Beth, I think with that we'll close. I want to thank you so much on behalf of the entire audience, including me, for your terrific presentation and for the discussion. It's such an important area of work. It's truly a hopeful vision for the future of the country if we could expand oral health in this way. And I think everybody's really excited about your work and appreciate it. So thank you. I'll turn it back to you, David.
Yes, it is a very informative webinar. I'm sure we could go on for another hour, really. So thank you, Beth, and thanks for Polly for participating. And thank you for those in the audience who showed up for our event. We really greatly appreciate your support. And on that note, I want to reemphasize this is the first in a new series. It's first in a new series focused on health equity. And as of right now, our next event is scheduled for May 20th, and it will focus on social workers' use of telebehavioral health during the pandemic. So I hope to see a lot of you again then. But with that said, I hope everyone has a good afternoon. Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.